Awesome. And
I gotta remember that. So, everybody have a good weekend? It was actually like, no?
studied all weekend.
What's our test today?
Therapeutics.
Today? All right. Well, study therapeutics at your peril. I might call you.
Can we quote you?
What's that?
In general.
Well, I mean, like in this hour. Yeah, you could, sure. Who's teaching that
Like,
right
well,
now?
yourself, you don't
Yeah.
Sherwood.
Sherwood? Oh,
Yeah.
yeah, she knows me well. Yeah. So, sure. No. Okay, this is important too. Okay, and also, today, I wanted to really briefly, since, we've obviously had snow days, etc., the plan is going to be, today I'm going to lecture on CHF and antiarrhythmics. On Friday, I'm going to lecture on anticoagulants, etc. On Monday, the day that's the exam review day, what I'm going to do on Monday is just basically, we've discussed pretty much all the agents that get used for hypertension. We never really discussed them as antihypertensives, so I'm just going to do a brief review of the drugs that are used as antihypertensives. You guys obviously need to know those. So that'll be pretty much a review. If you feel like you don't need it, you feel like you understand how those drugs like diuretics or beta blockers or whatever, if you feel like you understand how they lower blood pressure, you can do whatever you want that day. It's not like a required day. And then tomorrow, or Wednesday, we're going to have a quiz, brief quiz with 10 points. Again, it's diuretics and the renin-angiotensin system. And I've asked for a room 3:30 tomorrow, so anybody who wants to can review that first exam in hand. They haven't told me the room yet, but as soon as I hear that, I will send out a message to everyone regarding that. Okay? And I had some questions. I was a little, in looking over the material, I thought to myself, I may have left you guys a little dazed and confused with nitrovasodilators, because you've got all kinds of different things happening in different vascular beds, etc. So I thought I would ask these questions. And first one, what do nitrovasodilators do to ventricular filling? It's either lessen it or increase it.
Increase.
They lessen ventricular filling. Okay? You want to think ventricular filling is the amount of blood going into the ventricle, right? What do they do to myocardial blood flow?
Increase.
They're actually going to increase. So the vessels in the heart muscle, the blood vessels are getting wider, right? So you're getting, and the blood's is not actually moving as fast, but overall you're getting an increase in, among other things, oxygen delivery and myocardial muscle. Okay, so one thing I want to make sure you guys have those two. Those are separate things, right? Blood flow, to the ventricle is different than blood at the muscle, the heart muscle itself. All right. What do they do to preload? It's very similar to actually. As venous return is decreased. Okay. And then afterload, peripheral resistance. So afterload is the heart, how much pressure it needs to get the blood to the periphery. Nitrovasodilators are going to. You don't get an answer. Okay. Decrease it. Okay, they're relaxing blood vessels, right? But throughout, not just in the heart muscle, but other places, and they're having other effects. So again, you got a decrease in ventricular filling, and you guys know as we're going to discuss CHF today, right? Too much increased ventricular filling is part of the problem with CHF, right? Again, the vessels that are supplying the heart muscle themselves, that dilation that you get with the blood vessels there actually is going to increase the oxygen delivery, right? There, so increase the sort of ease of blood flow there. Okay, and then but they're going to lower preload, which is preload is how much that ventricle gets filled. So it's essentially the same question here. And then they're also going to lower afterload, okay, which is, you can think of it as the peripheral resistance. Everybody got that?
Mm-hmm.
Okay. Just wanted to make sure. Should we watch some videos or no?
Yeah.
I don't know whose this is. Okay. CHF. Congestive heart failure. And I stopped
Slide 10.
slide 10. Which one is slide 10?
The picture of the heart with the CHF
one?
Simplified. No, keep
Oh,
going.
no, with the
There.
backed up blood?
Yeah.
Okay. Okay, so CHF, and this slide shows CHF, congestive heart failure. Simplified, of course, congestive heart failure is defined by congestion. It's too much blood, right? Overfilling of the heart. Eventually the heart's not going to be able to take that. That blood's going to back up into the lungs, etc. So you have that congestive part, the overfilling part, and you're causing all kinds of stress to the heart wall and the heart muscle itself. So you start having failure of the heart muscle itself as well. And obviously, if somebody gets to this point, they're in big trouble. So I think part of your jobs as healthcare professionals down the road is going to be to help keep people from getting to this point where they have CHF. You do that by controlling blood pressure, etc. Okay, let's see. So another thing you want to know about CHF is that, of course, somebody has CHF, that they're going to have hypertensive issues or all kinds of different blood pressure issues. I'm going to leave it more open as that. And one of the things that happens with CHF, blood's not getting pumped where it needs to go, etc., is you do get an increase in sympathetic nervous system activity and an increase in renin-angiotensin system activity. So, your system realizes, okay, the blood's not getting where it needs to go, the heart muscle's failing. So you have essentially, the way I think of it is a stress response, okay? Stress response, the body needs to get back to its, homeostatic point that is physiologically safe. So you get increase in sympathetic nervous system and renin-angiotensin system activity. One thing that's maybe good you can think of is that you're going to get increase in heart rate and increased myocardial contractility to help push that blood out further and to where it needs to go. Unfortunately, you're also going to get increased peripheral resistance with this because you've got this increased noradrenergic input to vascular smooth muscle, so you're going to get contraction and increased mean arterial pressure. So, again, the body's trying to compensate it, but it's not really going to be doing it in a completely successful way. Okay, but these guys these two systems, the renin-angiotensin and sympathetic nervous system, their activity goes up, tries to help the heart compensate. Okay, this slide shows ventricular outflow resistance and stroke volume during diastolic dysfunction. So over here is stroke volume, right? That's how much blood gets pushed out, the heart contracts. And here's outflow resistance. So essentially, what's the status of your vascular smooth muscle? Is it hard for the heart to push the blood out, or is it easier? And as you can see, normal stroke volume would be up here, right? With an outflow resistance is relatively low. If somebody has hypertension, develops hypertension, and particularly if it's uncontrolled, that you're going to have an increase in peripheral resistance with hypertension. So you got outflow resistance. So as that continues, you're going to get a reduced amount of stroke volume. Okay? So the amount of blood that you'll be able to push out into the periphery is going to be less. Somebody's got the heart muscle, so myocardial dysfunction. If that's not working well, then if their outflow resistance is low, so if they can I don't know, 8 ARBs or something like that to keep their outflow resistance low. They can still get a fair amount of stroke volume, but then as they treat their blood pressure, their peripheral resistance increases, stroke volume decreases, so getting less blood out. And if somebody has severe myocardial dysfunction, essentially no matter what you're trying to do to outflow resistance, and no matter how much you're trying to lower the drugs, etc., it's still not going to be particularly successful. Got that? Okay, the drugs, which you've all been waiting for, right? So there's a bunch of different agents that are used to treat CHF. We've already discussed a lot of these, so you should, at least on some level, know their basic mechanism of action. Diuretics, of course, are going to treat the congestive part, going to try and reduce plasma volume with diuretics. Potassium-sparing agents, which are also very weak diuretics, but they're going to help. They're mainly just used to spare potassium that's lost when you use another diuretic like a loop diuretic. Of course, vasodilators can try and lower peripheral resistance, decrease overfilling of the heart, etc. with vasodilators. ACE inhibitors and ARBs, blocking the effects of the renin-angiotensin system. So that's going to decrease peripheral resistance. It's also going to decrease the stimulation of growth factors, etc., in the heart muscle that are going to cause the heart muscle, or help the heart muscle remodel in a not necessarily good way. Beta blockers get used for CHF, even though it's a little bit counterintuitive. You've got a failing heart muscle, and you then slow it down with a beta blocker. In the old days, they didn't do this, but nowadays they do use beta blockers. What are you doing with beta blocker in terms of heart muscle and how hard it's working? You're decreasing it, you're slowing everything down, right? So it's not working so hard, it doesn't need as much oxygen, etc. The drugs we haven't had yet, you guys, at least with me, cardiac glycosides, have you guys discussed those at all? Digoxin, okay. Inotropic agents and phosphodiesterase inhibitors. So I'm going to go over a lot of these, but those are the main ones you want to be sure you know the MOAs of those three, along with all the others. Okay, in terms of diuretics, again, these guys are used to treat the congestive symptoms of CHF. They don't actually reduce overall mortality. And conveniently written in italics is what you got to know absolutely, is that the main effect of diuretics is to reduce extracellular fluid volume and ventricular filling pressure. Okay, and you lower preload by doing this, and you can actually, at least earlier on, lower preload without reducing cardiac output. So these guys can help with CHF, especially early on. Also, dietary sodium restriction is also advised for people who have left ventricular dysfunction, so overfilling of the left ventricle. The diuretics that get used most often for CHF, of course, it's a serious condition, right? And these are serious drugs, so the loop diuretics, the high saline diuretics, okay, like furosemide, I'm not even gonna, I can pronounce torsemide, but this other one I'm a little afraid of, so pronounce it to yourself. What is it? Bumetidine? Bumetanide, okay. So, big thing, pronunciation is less important than knowing the mechanism of action, right? We all agree with this, I hope. Okay, anyway, loop diuretics are going to inhibit that sodium 2-chloride potassium symporter on the apical membrane of the ascending loop of Henle. Okay. Thiazide diuretics can get used as well, but less often than loop diuretics, and those guys inhibit that sodium chloride cotransporter in the distal convoluted tubule. Okay. Thiazides aren't as effective in part because of just where you're inhibiting reabsorption of sodium in the distal tubule. It's just not as effective when you're doing stuff there. Okay. So this slide, in real simple terms, shows the loop diuretic mechanism of action. And so over here in the yellow, we've got the lumen side of the tubule system, right? And we're in the thick ascending loop. Okay, so on the lumen side, under normal circumstances, this transporter will be involved in reabsorbing sodium, chloride, and potassium by bringing them across the membrane, and so they can be deposited back into the blood. You know, that's what's going to happen normally to recycle those guys, but with loop diuretic, you're blocking the effect of this transporter. Thiazide diuretics, you're blocking the effect of this sodium chloride symporter that under normal conditions is going to be pulling, and here through this right here is supposed to be the tubular fluid, right? So, and we're in the distal convoluted tubule here. Under normal conditions, the sodium chloride symporters involved in stimulating the reabsorption of sodium chloride here. You're blocking that effect here, so you're not getting it reabsorbed and not putting it in the blood. You're excreting it, and of course, as you lower down salt levels in the plasma, you lower overall plasma volume. Right? Okay, potassium-sparing diuretics get used with CHF, but they're mainly used to, of course, spare potassium when somebody else is taking another type of diuretic. Okay, so these guys aren't going to reduce extracellular volume very much, but again, they will help spare potassium and magnesium so that you don't get this excess loss of ions, which of course is going to screw up heart function if that happens. Okay. And this slide, just in real simple terms, shows again potassium-sparing diuretics. So what happens with these guys is you get this sodium channel inhibited down at the collecting ducts and the distal convoluted tubule. So sodium, instead of reabsorbing sodium, it gets excreted. This messes with the electrophysiological potentials at membranes, and part of what happens is the sodium isn't getting reabsorbed, right, and it's not being exchanged for potassium. Is largely what's going to happen. So potassium is going to stay in the blood as opposed to getting excreted like it normally would. Okay, renin-angiotensin system inhibitors also get used to help treat CHF. I went over renin-angiotensin system, of course, and the effects of it in terms of cardiac remodeling. So, as you remember, the system, which you absolutely need to know, is involved in mediating sodium levels, water retention, and aldosterone secretion. It's also involved in stimulating catecholamine release from the neural sources and adrenal sources. So neural sources would be increasing sympathetic outflow. And overactivation of this system, among other things, causes cardiac remodeling, and of course, it also causes high blood pressure. Okay, so ACE inhibitors and ARBs both get used for the treatment of CHF, and it's kind of interesting in the longer term when you use these guys, angiotensin II levels can actually return to pre-treatment levels if somebody's taking these guys long term. However, blood pressure, et cetera, is still lowered, which indicates that, like a lot of drugs, you know, they have an initial effect that's good, and a longer-term effect that's also good, but the body responds to that initial effect and kind of bumps up, for instance, angiotensin II levels, but you're still getting this positive long-term effect, and exactly why that is a little bit, it's not well understood. Okay. In terms of ACE inhibitor effects, of course, you're going to typically either lower blood pressure or it would stay unchanged, and some people, heart rate usually stays unchanged. Sympathetic nervous system activity is going to be decreased with ACE inhibitors, decreasing the activation of that. And AT1 or receptor antagonists, you guys remember what AT1 receptors coupled to? G protein coupled receptor couples to, what's the biggest effect, one really big effect of angiotensin II? cause vasoconstriction. Okay, so those receptors, vasoconstriction, of course, is going to be linked to calcium, right? So GQ, right? Okay, so these the ARBs can cause a more potent reduction in the effects of angiotensin II than ACE inhibitors do. However, and this is kind of a nuance for CHF itself, is they don't cause the increase in bradykinin and other signaling molecules that you normally would see with ACE inhibitors. If you remember, bradykinins are those molecules that are inflammatory molecules, but angiotensin converting enzymes, those guys also will break down bradykinins. So when somebody's taking ACE inhibitors, you can get this buildup of bradykinins, and that's actually in CHF thought to be a positive thing. Okay, exactly why, not sure. And I think I've changed one or two slides in what I've got here. I'm not sure if you guys have. Is this slide next on what you guys have? Okay, so this slide just shows the renin angiotensin system and goes over that and basically shows where ACE inhibitors, what they're going to do, and then angiotensin 1 receptor antagonists and their activity. And of course, the big difference is the effect on bradykinin, or one of the differences. Okay. Okay, the next drug I want to cover briefly, or set of drugs for CHF treatments, would be beta blockers. So, and kind of mentioned earlier, beta blockers used to be considered counterproductive to CHF. Instead, people would go the opposite direction. However, it's been shown that these guys work better. Or they've actually been shown to decrease mortality, so they can be used for CHF. And the agents that get used include metoprolol, carvedilol, and bisoprolol. And so, as you can see, some of these guys are going to be selective for beta-1, right, which is the beta receptor that's found at the heart. And that couples to what? G. When you activated it, it's stimulating heart. GS, right? Increased cyclic AMP, second messenger signal. Next, again, nitrovasodilators, like nitroglycerin, these guys get used to treat heart failure as well. So they increase the ease, I don't know if this is a great term or not, the ease of blood flow to and from the heart. So you're causing vasodilation with these nitrovasodilators. And again, blood flow, you're actually going to reduce preload and you're going to reduce afterload with these guys, okay? Because you got the blood vessel walls are relaxing, they relax to the point, the blood's not under such high pressure that it's going to be zipping through there. Okay, if you remember the mechanism of action of nitrovasodilators, they're nitric oxide donors, okay? And so what nitric oxide then is going to do, NO is going to be produced, and it's going to increase cyclic GMP levels, and that's going to cause vasorelaxation. So here in this slide, we've got sodium nitroprusside, nitric oxide donor. That leads to the production of nitric oxide, NO then, and this is going to be a smooth muscle cell. Okay, it's got this NO, stimulates guanylyl cyclase, so you get an increase in cyclic GMP, second messenger signaling, and you're going to get vasorelaxation with that. So you're gonna, what you're really doing is you're decreasing myosin light chain phosphorylation. Okay, so sodium nitroprusside, again, is one of the agents that gets used for this. It's not selected for venous versus arterial vasorelaxation, so you get both. Also, somebody's in dire straits, IV nitroglycerin could also be used. But if you remember, tolerance for those guys, for these NO donors, can develop. And the main way to stop tolerance, of course, is to reduce their use. So these are going to be tricky to use for this stuff. Hydralazine, next CHF drug I want to briefly cover. When you think hydralazine, think nitric oxide. And so basically you're working with a cyclic GMP second messenger system with hydralazine, so it's a lot like nitric oxide. So what this does then is it stimulates cyclic GMP second messenger signaling. You get this decreased myosin light chain phosphorylation or phosphorylation in vascular smooth muscle. So you're going to get relaxation of vascular smooth muscle. And with this stuff, you can reduce ventricular afterload by lowering pulmonary and systemic vascular resistance. So you're relaxing those blood vessels going to the heart. You're also relaxing the blood vessels at the level of the lungs. And also, the body's going to respond to this stuff, and you're actually going to get an increase in sympathetic nervous system activity with this, which of course is going to make the heart beat faster. But in the vasculature of vascular smooth muscle, that NO effect is going to override that increase in sympathetic nervous system activity. So the actual increase is going to be more due to the increase in heart rate. The benefit of this is going to be more due to that sympathetic outflow to the heart. Okay, and this slide shows hydralazine and nitrovasodilator mechanism of action. And I don't know how you can see this, but we've got smooth muscle here. Both nitric oxide and hydralazine are going to stimulate guanylyl cyclase activity, and I just wrote over the top of that, sorry. Anyway, you're going to get an increase in cyclic GMP second messenger signaling. That then is going to cause a reduction in myosin light chain phosphorylation, vasorelaxation. For our purposes, I want you to know at least to the level of an increase in cyclic GMP second messenger signaling causing vasorelaxation. I'm not going to get into the whole myosin light chain, so it's a little bit much for our purposes right now. Cardiac glycosides, next class of drugs. I'm going to very briefly cover cardiac glycosides like digoxin. These guys are a little tricky, so you might want to stop with the therapeutics for a second and pay attention. Okay, cardiac glycosides are highly selective inhibitors of sodium-potassium transport across myocyte membranes, so heart muscle cell membranes. And what these guys do is they inhibit the sodium-potassium pump and stop its function. As we'll see, what happens after that is you're going to get, so you're stopping the extrusion of sodium by inhibiting a sodium-potassium pump. Again, we're in heart muscle cells, right? And so by doing that, you're going to get a buildup of sodium and inside the cell. That buildup of sodium is in turn going to mess with a sodium-calcium transporter that normally would be transporting calcium out of the cell. Okay, and so that's not going to work like it normally does. So what happens is you get an increase of calcium in the heart muscle cells. So you got increased calcium in a muscle, you're going to get increased ability for contraction, right? So heart muscle is actually going to work better with these guys. Okay. So, and as the slide says, then intracellular calcium levels get increased with cardiac glycosides. Among other things, that calcium is going to get stored in the sarcoplasmic reticulum. So when those stores are signaled, or the sarcoplasmic reticulum is signaled to release its calcium stores, it's going to release more calcium than it normally would have. So you're going to get an increase in contraction with that. Okay, so, and first then here in italics is a really big point. Cardiac glycosides, you get that increase in calcium-driven heart muscle contraction. Okay, and of course, CHF, that heart muscle that's failing, this is going to help it contract more strongly and help eject blood to the periphery where it needs to go, and also help it keep the blood from, for instance, pooling into the lungs. Okay, so this slide shows cardiac glycoside mechanism of action. So this is where the cardiac glycosides are going to bind. So this right here is a sodium potassium pump, okay? So under normal circumstances, this pump is going to pump out sodium, okay? Exchange it for potassium. You guys are very familiar with sodium potassium pumps, correct? And these are specific to, this particular type is specific to heart muscle. Okay, so what happens is you block that, you get an increase in sodium within the cell, okay, within the myocardial cell. That in turn is going to, and I think I actually, yeah, I did animated this, so you get that increase in sodium. That in turn is going to block normal activity of this sodium-calcium exchanger. So under normal circumstances, that this pump here, that under normal circumstances, that pump is going to send calcium out of the cell, but that it's going to stop functioning normally, so you get a buildup of calcium as well. Okay, and then buildup of calcium in the cell. You know, that calcium will be around. It'll also be stored in the sarcoplasmic reticulum, and then be released when that's stimulated. So you're going to get an increase in inotropy, increase in force of contraction. Okay, and that of course is going to help eject blood out. Next class of drugs, going to cover just a couple slides here. Phosphodiesterase inhibitors. You guys been over phosphodiesterase inhibitors anywhere yet? Yeah, you're actually probably aware of a couple of them. But anyway, enamorone and milrinone, these guys are both phosphodiesterase inhibitors. And what they do is they, among other things, inhibit phosphodiesterase 3. It's a phosphodiesterase that's involved in regulating heart muscle and vascular smooth muscle. And what phosphodiesterase E normally does is it stops second messenger signaling, so it stops cyclic GMP and cyclic AMP second messenger signaling. If you inhibit that, you're going to cause overall an increase in cyclic GMP and cyclic AMP second messenger signaling. So it's a double whammy effect. So and that increase in cyclic AMP is you're going to get cause an increase in inotropy or contractility. It'd be the same thing as, for instance, causing a beta-1 receptor at the heart to be activated. Get increased, beta-1 receptor coupled to GS is linked to increased cyclic AMP second messenger signaling, and that, of course, at the level of heart is going to drive those cells, heart muscle cells, to contract. So with this guy, you're lengthening that cyclic AMP second messenger signaling. You're also lengthening the cyclic GMP second messenger signaling, which is going to cause vasodilation. So you're increasing contractility, and you're also causing vasodilation, which, both things that are going to be good for the failing heart. Okay, and one way to think about these phosphodiesterase inhibitors is they can mimic sympathetic nervous system activity, also mimic nitric oxide signaling activity as well. Okay, and again, the effects with the phosphodiesterase inhibitors got this increased cyclic AMP and increased cyclic GMP second messenger signaling, so you get an increase in inotropy, contractility, etc. And you also get vasorelaxation. So you should at least know those two really big points of increased contractility, increased heart muscle function, or ability of the muscle to contract, and increase in vasorelaxation. Okay, the next class of drugs that are going to be reserved for somebody who's like really down the road with CHF are inotropic agents. So we haven't really discussed it, but there are dopamine receptors on the heart as well as beta receptors, and you can use agonists of these guys to support heart function if somebody's got an advanced CHF issue. Okay, so there's things like for beta agonists, kind of highlight this because you want to know dobutamine is a beta adrenergic receptor agonist that can be used. Okay, but basically you're just activating those beta-1 receptors on the heart muscle and causing it to beat better that way, harder, faster, contract. Dopamine is actually given as the dopamine agonist for this. And of course, you're giving these drugs that are activating dopamine receptors and, beta receptors. And of course, you're going to have an effect at the heart, but there's also potential for all kinds of other effects. Because as you know, these receptors are found all over the place and do lots of different things. So, it's not something you're going to do willy-nilly to give somebody an agonist like that. And here's a slide that for you guys to study. It's basically, it's a good slide because it goes over all the drugs that get used for heart failure. It doesn't actually have their direct mechanism of action, but it does have their physiological effect here. So if you can walk yourself through this slide, you say inotropic agents and digoxin. Okay, I know inotropic agents are fine, directly activate beta or dopamine receptors at the level of the heart, so they're going to help there. Whereas digoxin, of course, is going to block that sodium-potassium pump, cause a buildup of calcium in heart muscle cells, and so you're going to improve contraction there. And anyway, you can walk yourself down through the drugs on this slide and see what they do. And hopefully, if you can do that, then you should really understand how these drugs work. But I would also throw in, as you're looking at this, throw in the mechanism of action as you're studying it.